Good afternoon, everybody. There's not too many of you there yet, but I expect there to be a real large crowd of people joining me today. I'm very, very excited about doing this particular seminar. It's going to be double the normal length. The focus is going to be on endometriosis. I'm not going to talk much about it now because there are more people signed up and ready to go, but it's a very important subject. Obviously, we'll also take questions, diverse questions on infertility and IVF in general, but the focus today is on endometriosis. So those of you that have questions relating to this very common condition, please let them roll because we'll be ready to go. In the meanwhile, whatever questions are there, we may as well start whenever you're ready. And again, Josh Bell is with me. Josh does a wonderful job as videographer, takes all the questions and tries to pronounce the words correctly to get to me. But we're ready to go. Do you have anything for me, Josh?
We've got a few questions in here. Do remember, guys, please comment any questions you have for endometriosis, and we'll answer them as soon as possible. I'm going to answer Miss H here on TikTok. She says, "Hi, what does non-stop period and blood test normal mean?"
What?
A non-stop period, but blood test normal. What does that mean?
I'm sure it's a tough one to start with because I think you mean someone who's bleeding continuously and not having a stop at the right time with the periods. That means you're bleeding excessively and prolonged. And when a person bleeds like that, it can either be due to something being abnormal inside the uterus, like a polyp or a growth or a fibroid. It can be irregular hormonal balance, completely out of kilter. There are many causes for prolonged continuous bleeding, but I don't think I can go any further without much more information as to what you really mean.
Alright, I'm waiting for a few more questions here to come through. If you have any questions on endometriosis, please comment it. We'll answer it today. We're going over a full live stream that's focused on endometriosis. We'll answer Miss Shelby here. She says, "What is your take on beef organs struggling to conceive after have 4 kids before?"
My take on what?
On beef organs. She says, struggling to conceive after having 4 kids before.
I don't know what you mean by beef organs.
I'm not sure. Miss Shelby, if you have an answer for Dr. Sher of what beef organs you mean. Do you mean consuming organs?
I don't think it's got anything to do with fertility, quite frankly, but if you've got more clarity, I'd be happy to address the question.
She says it's a supplement for the heart and soil, yes.
I don't think it'll do any harm to your fertility whatsoever.
Nessa says, struggling to conceive. I have 1 kid, did all my tests and scan, all is okay. Any information?
Well, you clearly need a thorough evaluation to see what's going on. You can't treat something unless you know the cause. So you need to be evaluated by a fertility doctor. And the key issues there, it's a lengthy answer, but you need to have your ovulation checked to see if you're ovulating normally with a proper hormone balance. You need to check to see if your tubes are open, your fallopian tubes. That usually requires a baseline test called an HSG or a hysterosalpingogram. You need to have your husband's sperm properly evaluated. And then you need to see whether you've got a normal hormonal balance, which means blood levels of hormones about a week after you've ovulated, and sometimes that is included with that is a biopsy of the uterine lining to see if the changes induced by the hormones are appropriate in the uterine lining, and that's got to be in sync. And then, of course, it's important to know that you have got no other underlying conditions like diabetes or polycystic ovarian syndrome, or all these things need to be looked at. You need to have a thorough evaluation. Simply put, take your basal body temperature every day to see that you're ovulating around the middle of the month, and at that point the temperature will rise and stay up by a degree or 2. You can do home ovulation testing using the dipsticks you can buy over the counter, which tests ovulation, or the LH surge, by dipsticking your urine from around the 10th day of the cycle onwards to see when the color change occurs, which indicates that you're about to ovulate. And then finally you can check to see after intercourse around the time of normal ovulation whether or not your husband's sperm is surviving in the mucus at the opening of your cervix, which is the entrance to the uterus, and it should have plenty of sperm swimming around in there for there to be easy passage of sperm into the reproductive tract to fertilize the egg.
I want to answer this question right here. It says, do you know how endo is treated in the US versus the UK? Past to diagnosis, treatment, UK patient here. Just curious about how they do treatment over the pond.
Well, how many people do we have there yet? Because I want to start leading into endometriosis. Are we building?
We've got about 50 in here, and then about 5, 6 on here.
Okay.
So
let me start by answering it by an introduction. And this is going to be placed on YouTube as well, so you'll be able to watch it again if you're interested. Endometriosis is a very, very common condition in infertility clinics. 25 to 50% of women who attend infertility clinics have got endometriosis either as the cause of their problem or as an adjunct to the problem. It is a condition where the inner lining of the uterus, the endometrium, grows outside of the uterus on the organs in the pelvis or on the membrane that envelops all the organs in the pelvis, known as the peritoneum, and can spread from there. I'd like to make a point. All women who have open fallopian tubes will at some time or another menstruate backwards through their tubes. The blood which issues out of the ends of the tubes, which hang over the ovaries like shower heads, spills over the ovaries and into the pelvic cavity, mixing in with the secretions within the pelvis. The membrane that covers the pelvic organs, the peritoneum, is porous, and some seepage occurs of fluid into the pelvic cavity, the purpose of which is to allow all the organs to slide over one another easily. And what happens is that when the blood trickles out of the ends of the tubes, and as I said, this happens in all women, not just women with disease, some of these cells will grow on the surface of this peritoneum. In fact, they love to grow there. And under the effect of estrogen in the first 2 weeks of the cycle, these deposits grow thicker and thicker. And then in the middle of the month, the woman ovulates, and now she releases the second female hormone called progesterone. That signals her immune system to send janitorial cells, which are called macrophages, through these pores in the peritoneum into the pelvic cavity, and then they look for these deposits and they gobble them up like little Pac-Man. Those of you that are as old as me will remember the game where these little Pac-Man gobble things up, and that's what it does. It attacks these deposits and then spits them out. So by the time the next period comes, the whole area is clean again and everything starts over. That's the normal sequence of events. Now in some women, and these are usually women that you can typify that have classic features, they tend to be living a slightly highly stressed life. They type 1, type A personalities, overachievers, take charge individuals. They're usually the professionals and a credit to their gender. These are the type of women that live at a slightly higher intensity, which affects the immune system's ability to send these janitorial cells down and clear out the room for the next session. And in those cases, these deposits remain, and now month after month and year after year, they build up. And they get so thick that now when the woman menstruates, she actually menstruates into these deposits on the peritoneum. This stretches the deposits, causes congestion in the pelvis, pelvic pain, manifested as pain with periods, pain with ovulation, or pain with deep penetration during intercourse. Now, here's the important point. These deposits are now so thick that when the woman menstruates, they don't just disappear. They absorb, but the blood inside of them, the menstrual blood, which contains red stuff called hemoglobin, which is mainly an iron compound, and now this hemoglobin absorbs, leaving telltale signs of a pigment, an iron pigment called hemosiderin, in various locations in the pelvis. And when the doctor goes in and does a laparoscopy and looks into the pelvis through the belly button, he sees these deposits that look like gunpowder burns or pigeon eyes looking at him and says, you know what? She's just developed endometriosis. But that's not correct. That condition has been developing all through the woman's reproductive life. It may first manifest, but it's causing problems even beforehand. And these deposits release toxins or inflammatory substances into the secretions of the pelvis. And now what happens, here's the egg coming from the ovary to get into the tube to be fertilized by the sperm, crossing over this hostile, toxic environment. And guess what happens? The egg is like a chicken egg. It's got a shell around it called the zona pellucida, only it's as large as a grain of sand. And in the process of traveling from the ovary across the gap to reach the tube, these toxins get into the shell of the egg and compromise the ability of the egg to be fertilized properly. And so what now happens is that the ability of an egg that left the ovary normal, by the time it gets to the tube to be fertilized by a sperm, is now 5 or 6 times less likely to fertilize. Now, sometimes they do, and that explains why women sometimes get pregnant, but it's much more difficult. So if the normal chance of a woman, let's say in her mid-30s or early 30s, having a pregnancy per month of trying is about 20%, now it'll be 3 or 4%. And that means that instead of there being an 80% chance of getting pregnant per month of trying, per year of trying, it'll now be about 40% in 4 years. What this means is that women with early endometriosis, sometimes even before you can see any of these lesions, while they're still in the process of developing, will have a reduced fertility potential and will often present as so-called unexplained infertility. It's not really unexplained, but it's hard to identify it in the early stages. But the point is that the ability to get pregnant per month of trying is dramatically reduced. And that's why women with endometriosis aren't necessarily always sterile, but they have reduced ability to conceive per month of trying that is dramatic. And going in to do surgery, to remove those spots you can see, those deposits you can see, by lasering them or ablating them with heat, doesn't improve fertility. Because for every one you can see, there are probably another 30 or 40 coming up. Endometriosis is a for-life condition. It's a gift that keeps on giving. The woman has got a problem that stays with her, so it's hard for her to get pregnant and remain pregnant. So for this reason, doing surgery to remove the spots does not, in women with early endometriosis, will not improve her chances of getting pregnant over no treatment at all. Also, a procedure that I introduced in the field of medicine called IUI, or intrauterine insemination, which I introduced in the early 80s. That situation of doing IUI also doesn't improve the chances of getting pregnant over no treatment at all, because the eggs still have to pass from the ovaries through the toxic environment to get to the tube to fertilize the egg, and in the process they're compromised. So that means that when you do IUI or you do surgery in early endometriosis, you're not improving the woman's chances, in my opinion, to achieve a pregnancy. If she gets pregnant under those circumstances, it's usually in spite of the treatment and not due to it, which is one of the reasons IUI is relatively contraindicated for women with endometriosis, unless the woman's got an ovulation problem, and even then, if you make her ovulate, her chances of getting pregnant per month of trying are no more than 3 or 4%, as compared to 20% if that problem wasn't present. So endometriosis is a treatment that where you will not improve outcome by doing surgery or IUI, regardless of the severity. And sometimes women who don't have any signs of endometriosis but are in the process of developing it while they're still called unexplained infertility are also unable to achieve a pregnancy. Truth be known, the only thing that improves the chances of a pregnancy for endometriosis is IVF, and don't let anybody tell you otherwise. Yes, some women with endometriosis do get pregnant on their own or do get pregnant by other methods, but remember, if they then come back trying to get pregnant again, the chances are no better than no treatment at all. IVF removes the eggs before they're released. They're still in good condition. They're not being damaged by the toxins in the pelvis. And now if you fertilize them outside the body and put the embryo inside the uterus through the cervix, now you've bypassed the toxic environment. And these women often do get pregnant, provided there's no other reason for the pregnancy not occurring, such as failure of the embryo to attach to the wall of the uterus. And we'll talk more about that later on. That's called implantation dysfunction. And usually in women with endometriosis, 1 in 3 will have an immunologic deterrent, the embryo implanting. 1 in 3 will have certain cells in the uterine lining that attack the embryo and destroy it. These are activated natural killer cells. They're immune cells that all women have got and must have if embryos are to attach. But in endometriosis, they start to release toxins that attack the embryo's roots, destroy it, so the woman loses the pregnancy before she even knew she was pregnant. So you can have a problem with the ability of the egg reaching the tube where the sperm is in a good enough condition to be fertilized because of the toxic environment. And then if for any chance an embryo is formed and then reaches the uterus, in a third of cases it still won't take because of an immunologic implantation dysfunction. So when you treat endometriosis, you've got to be very, very suspicious. You've got to check for all these problems and address the nature of the problem to improve the chances of pregnancy occurring. Hopefully you'll get back to more of this with additional questions in the course of this discussion. But that's what endometriosis is about. And the use of surgery to diagnose it will diagnose it, but you don't need to do laparoscopy anymore to see the lesions in the pelvis, which used to be the traditional way of doing a diagnosis. Today there are other tests that you can use. One is called the Reproductive test or the BCL6 test, which you do a little biopsy of the uterus and test for certain markers in the uterus which tell you if the woman's got endometriosis. With 90% confidence, it's as good as doing laparoscopy to look, and you don't need the surgery, the expense, or the trauma, or the pain. So doing Reproductive test is good. So you don't need to use surgery for the diagnosis of endometriosis. And if you do surgery to treat it, you're really not improving matters unless it's very advanced endometriosis that has damaged the outside of the tubes and blocked them. And even then, surgery isn't the way to go because IVF is the right treatment if you want to improve chances. And if you place attention on getting an egg from the ovary with the right stimulation to make sure you don't compromise the eggs, then you fertilize it, make embryos and test the embryos genetically by PGTA to see if they're normal, and put a normal embryo into a uterus that has been tested and evaluated for an implantation problem, and that problem's then been addressed, the chance of pregnancy should be as good as if you never had the problem in the first place. But it requires an individualized approach to ovarian stimulation and an individualized approach to diagnosis.
Okay, I'm going to answer this question here for endometriosis. It says, oops, I just lost it. They're asking if you have any stories of someone with endometriosis getting pregnant after. Can you give a case study?
I can't tell you how many. About half of the patients we treat have some element of endometriosis, and many of those have an implantation problem. Again, if you address the underlying causation, make sure that you are bypassing the toxic environment by doing IVF, retrieving the eggs after you've used a very individualized approach to ovarian stimulation so as not to compromise the eggs. You use the right protocol, and then you put the embryo that you get after testing it to make sure it's chromosomally normal or euploid into a receptive uterus, or one that's been rendered receptive through selective treatment of the underlying immune problem. You'll be able to achieve a pregnancy as easily as if there was no problem at all. It requires a seed, which is the embryo, and it has to be a good quality embryo, and that you do with the right protocol and proper testing of the embryo using PGTA. placed in a uterus that is receptive, meaning that you've identified and addressed any immunologic issue that's preventing the embryo from attaching. So I know there are a lot of you that want to know more about this. All you've got to do is go to the link on my bio, click on that link, and that link will take you to an area where you can actually get free downloads of books that I've written on this subject. I urge you to download them free of charge, get copies, and read up on endometriosis. And to make it even easier, I and my colleagues have written a recent article for you, a very comprehensive and up-to-date, step-by-step approach to dealing with endometriosis with clear explanations of why these treatments are required. All you've got to do to get that is click on the link which gets you the books free of charge. And if you then get the books, you'll also get the article that we've written. And if you read those, you can understand a lot more. Now, there may be some of you that are interested in talking to me about your problem. I'd just like to say that if you click on that same link, you'll get two choices. One is to get the books and the article, and the other one is to set yourselves up for an online consultation with me. What will happen is when you click on the link that asks for that, a questionnaire that is only 3 to 4 minutes long to fill in will appear, which makes you eligible for a consultation one-on-one with me online. In that consultation, I'll review everything you've told me and more questions that we'll address when we speak, and I will send you a very clear report outlining exactly what I think needs to be done, an individualized plan which will go to you afterwards. But to get that consultation, it's important that you indicate on that form whether you have insurance, medical insurance in the United States that covers medical consultations. If you do, we'll gladly bill your insurance for the consultation. And if you don't, for those that still want to talk to me, there's a nominal fee of $250, which is for the consultation. But you can talk to us about that, and we'll see how we can help you. It's very important for you to know that all the people I consult with get access to my contact information. And it comes to you in the form of my telephone number, my cell number, which I give to everybody I talk to, all my patients. And that cell phone number you can keep with you and use it even if you don't ever come to me for treatment. And I will be very happy to talk to you and help you through any problems that emerge. And you'll have that permanently to be able to reach me by phone. Again, all my patients get my number with an invitation to call me on any questions, issues, concerns, recommendations. I like to do that. It makes me feel good because I'm able in this way to help inspire and educate you and see you through from infertility to family.
Alrighty, I'm going to pin this comment here. Helen on TikTok said, "Hi doctor, can endometriosis be seen through an ultrasound?"
Very, very good question. Question was, can ultrasound diagnose endometriosis? The answer is only if it's more advanced, such that it's causing structural lesions. And even then, if there's a lesion in the pelvis, you won't know if it's endometriosis or infection or anything else causing it, unless there's what we call an endometrioma. Please listen carefully to this. And again, in that article that you can get free of charge with the books that you download, that you click on the link and get the free books from us. An endometrioma is a cyst that contains menstrual blood that is decomposed, degenerates, so that then it looks like melted chocolate, hence the name, a chocolate cyst. If these endometriomas are present in an ovary, they'll irritate the tissue in the ovary and compromise the eggs produced by the affected ovary, such that the eggs coming from that ovary will be very much compromised and less likely to make chromosomally normal or euploid embryos that can make a baby. The other ovary, if there are no endometrioma in it, that ovary may be able to produce good eggs, but the one that's got an endometrioma that is sizable, which means more than 2 centimeters in size, will produce too much of the hormone testosterone due to the irritation of the tissue in the ovary, Now, all women need some testosterone to make estrogen, to make their follicles grow and the eggs develop. But you don't want too much. And if there's overproduction of testosterone, it gets into the fluid of the follicle, compromises the egg in its development, and those eggs, upon being extracted and fertilized, are much less likely to be able to produce a competent or chromosomally normal embryo. So it's really important to know that endometriomas must be removed, in my opinion, if they're more than 2 centimeters in size, from the ovary before you go into IVF, and you shouldn't do IVF for about 6 to 8 weeks after you've removed it. And sometimes that leaked out of the cyst into the pelvic cavity, causing a tremendous irritation of that membrane I told you about earlier that envelops the pelvic organs, called the peritoneum, which is rich in pain fibers. And the woman would have very severe pain. Roughly 1 in 8 to 10 women we did this on had this problem, and it didn't make us very popular, so we didn't expand the use of it. Well, there's a new sclerosing agent now called ethanol, alcohol, 95% alcohol, which does exactly the same as the tetracycline did, just as effectively, and does not cause this complication of pain and the side effect. So you can actually inject it into the cyst, leave it there, and the woman can go home straight afterwards, after she wakes up after the conscious sedation, and the problem's gone. There's no pain, there are no complications, and the success rate is about 85 to 90%, just as good as with surgery. You're not removing ovarian tissue, so you're not compromising ovarian reserve, as I mentioned earlier on. The risks and complications are negligible. In about 10 to 15% of cases, the cyst reappears, but this time it's filled with a clear fluid, not blood from menstrual blood like before, and all you then do is go in and drain that fluid out, the cyst collapses and the problem's gone. So sclerotherapy, please remember this, is in my opinion the treatment of choice if ultrasound shows an endometrioma. It is a benign, easy, successful, simple, relatively pain-free and inexpensive approach. Oftentimes, because it involves the removal of an ovarian cyst, which is what an endometrioma is, insurance will cover it. So using sclerotherapy offers a tremendous opportunity for women with endometriomas which need to be removed for the reasons I gave earlier on, which need to be removed about 8 weeks before you go into a cycle of IVF. By the way, if you did surgery, you'd still have to wait 8 weeks for the ovary to recover before you could do IVF anyway, and this procedure is equally effective, pain-free, and virtually without risk. If you want to know more about sclerotherapy for endometriomas, 2 things. 1, that article I'm giving you, along with the 2 free books, talks about the sclerotherapy. The second thing you can do, and because not many people are familiar with this approach, which I believe is a game changer, and much of a game changer as the process I introduced into IVF several years ago, 20 years ago, with Dr. Drew Tortoriello, my medical director in New York, called PGTA, was a game changer to try to identify the best embryos. Sclerotherapy, since endometriosis is so common in IVF patients, is a game changer for people that have got endometriomas or chocolate cysts. And I urge you, therefore, to fill in the questionnaire that you'll find by clicking on the link and booking an online consultation with me. Again, for those of you that have insurance, medical insurance in the United States, we will bill you insurance. If not, there's a nominal fee of $250, which is very reasonable, and that gives you an hour-long discussion with me to go over the problem and for me to help you solve it. We have a program set up to do sclerotherapy in our program in Manhattan, and I can give you all the information you need to get that done.
Awesome. I'm going to answer this question right here for why does Lupron suppression help so many women after multiple failed transfers with endo?
You just brought up another topic that to me is very controversial. Please listen very, very carefully. The purpose of getting Lupron is to stop the ovary producing estrogen. Estrogen is needed to make the lining of the uterus thicken. And of course, since the endometriotic deposits contain endometrial tissue, using Lupron stops them from growing. First, it's only temporary. It's only while you're on it, and the moment you stop it, within a couple of weeks you're back where you started. So it's not effective in the long term. Second, when you get Lupron to suppress endometriosis, you take Depo-Lupron, where you take a shot every month, and it has a prolonged effect, and that sends your ovary into a quasi-menopause. It stops producing estrogen. It blocks ovarian production of estrogen. And here's the problem. If you block ovarian estrogen for a period of months, what happens is that the uterus forgets how to respond to estrogen, because it's the very estrogen produced by the ovary that makes the endometrial lining resilient and able to recognize estrogen by priming estrogen receptors in the cells of the endometrium. So when you take Lupron or the equivalent agonists such as Superfact or Buserelin, if you take Decapeptyl, which is the same thing, it will suppress estrogen production, make the endometrium resistant to estrogen. So now you've got another problem. The lining doesn't develop properly. And when you put the embryo in the uterus won't allow the embryo to attach itself, because it doesn't thicken and develop properly because of prolonged exposure, a long absence of exposure to estrogen. So that's why I don't believe there is a real place for using agonists such as Buserelin, Lupron, Decapeptyl, or other ones like that to suppress estrogen production in the ovary, in the hope that that will improve your response during stimulation. The only time I ever recommend using these agonists like Lupron is in preparation for major pelvic surgery, or if you're about to do clearance of the pelvis in some women with advanced endometriosis who need a hysterectomy. I don't believe there's a rightful place for the use of Lupron or the equivalent in women undergoing suppression before ovarian stimulation, yet I recognize many people feel differently. I don't agree with that position, and I have good reason after almost 40 years in the field for believing that I'm right in this regard. So again, Lupron, Buserelin, Decapeptyl, these are all GnRH agonists which I don't believe have a role in the prolonged preparation to suppress the ovaries for stimulation in IVF. They certainly don't have a role in treating endometriomas. They will not cause them to absorb, and as far as I'm concerned, shouldn't be used in the infertility treatment for endometriosis, in the same way that I think that surgery such as laparoscopy to diagnose endometriosis, or even to remove endometriomas, which can now be more easily removed through sclerotherapy, is the way to go. I urge you, if you have more interest in this, and you should have, please go to the link on my bio, click there, get the books and the article that I'm giving you free without condition. Read it, you'll understand a lot more. And if you really want my input, I urge you to click on the other option, which is to get access to the questionnaire that you can rapidly fill in within 4 minutes. And that questionnaire then comes to us, and we will then reach out to you from our end to set you up with an online consultation with me. If you choose to, you're not under pressure if you choose to. But if you do, and you have medical insurance in the United States that covers, we will accept insurance coverage for that visit. And if you don't, or you're from out of the country, it's a nominal fee of $250 to have a 1-hour consultation with me to discuss treatment and how you should proceed.
All right, we got a lot of endo questions coming in, so I'm going to read off this one here real quick. It says, I've been living with endometriosis for over 10 years and have had 4 surgeries. I still suffer. Is there any advice you have for them?
Well, the question is, I guess your question does not have to do with infertility, but rather due to the pain you experience from this advanced condition. I know this well. My own daughter had advanced endometriosis and needed to have definitive surgery to get rid of the pain. She'd had one child before, so her choice in her mid-40s was easy. She went in and cleared the pelvis of her uterus, and that got rid of all the deposits and pain and her ovaries. But again, the pain with endometriosis, if you want to preserve fertility, doesn't involve removing the uterus or removing the ovaries. You may get temporary relief if it's purely for the purpose of pain by using Lupron or other agonists, but not if you're trying to get pregnant for all the reasons I gave you. So yes, if you've got severe pelvic pain, usually it comes in the form of chronic pelvic pain, pain with intercourse with deep penetration, pain with ovulation, and heavy protracted bleeding. So if you've got any of those problems, if you have pain with your periods that are intractable, the pain with endometriosis with the periods is typical. It occurs where the pain begins once the period begins and gets progressively worse as the period goes along because of the buildup of the tissue that is the endometriotic deposits. Whereas when pain is caused by previous pelvic infection, such as with gonorrhea or chlamydia, causing chronic pelvic adhesions, or even after a chronic appendicitis, this pain usually starts before the period begins for a few days, and when the period starts, the pain goes away. That's a clear distinction of what happens with endometriosis pain with periods. Treatment is to use symptomatic relief by using things like the agonist that I mentioned. Some people use male androgens to suppress it. And there's another condition you can use, which I've used in the past. It's called a presacral neurectomy. The sacrum is the bone at the end of the spine that goes into the pelvis, the tailbone, the whole big tailbone. And over the top of that bone, some nerves go in to feed the organs, including the uterus, the tubes, and the pelvic peritoneum. These nerves are called the presacral nerves. If the doctor knows what he or she is doing, they can go in and transect and cut out a small segment of those presacral nerves, and the pain will disappear. That doesn't mean the condition's cured. It goes on unknowing, so you've got to keep watching very carefully by regular physical exams and ultrasound to make sure that the condition isn't exacerbating. But it does remove the pain as well. It's called a presacral neurectomy, and it averts the need to remove the uterus.
Okay, so I'm going to answer this one, but there's a lot of questions coming through about sclerotherapy, or how did you say it?
Sclerotherapy.
Sclerotherapy. So can you remove endometriosis through sclerotherapy?
The endometrioma is a cyst in the ovary full of chocolate-looking fluid, which is decomposed menstrual blood. I've seen them this large as a melon, or they can be as small as a little kumquat. That is endometriosis, and when you go in doing sclerotherapy, you get rid of that permanently. That doesn't mean others won't grow as well. They can come up again because the same predisposition occurs. There's nothing you can do about that. But the truth of the matter is that sclerotherapy is a surgery that does get rid of that particular problem of the endometrioma, and it is, in my opinion, a game changer. I know that you won't get a lot of information about this out there. So for those of you who want to know more about sclerotherapy, we really do need to talk. And I'd be more than happy to discuss it with you. But in the interim, get that article that comes along with the 2 free books that I send you by clicking on the link in my bio. And it'll give you all the information that you want to start with. But then there's a lot more to discuss. So I urge you then to maybe contact us by clicking on the link that gets you the questionnaire to fill in for an online consultation with me. Patty will get a copy of that completed questionnaire, and we'll set up a consultation online with me for an hour where we discuss your case in detail, and when I'm through, I will send you a copy of the report which tells you exactly what we discussed and what I think you need to do. Take advantage of that.
Alright, someone on, actually no, it's Tam Benito, they're a returning viewer that's been with us a couple times here. They said, can endometrioma go away on its own?
Very, very unlikely that it will ever go away on its own. Some of them grow slowly so they don't get very large, but it's not likely it's going to disappear on its own.
I'm going to answer this one real quick. Queen, I don't know how to pronounce that last name, I'm sorry, but I'm going to answer Miss Queen here. It says, can I get pregnant with stage 4 endo? I'm 30 years old, an AMH of 1.35. I had an endometrioma and adhesions. Any advice for them?
Well, I'd firstly assume that somebody went in and removed your endometrioma. That's what you're implying. And in the process, as I told you, one of the problems is that you sometimes lose quite a few eggs as you excise the endometrioma or laser it away. Sclerotherapy that I've described now averts that problem. So can you get pregnant with stage 4 endometrioma? Absolutely you can. It all depends upon the quality of the eggs you produce, and since you're young, the age is in your favor. At your age, 3 out of every 4 eggs should be normal, provided, let me emphasize, provided that the protocol used for ovarian stimulation in a woman like you who has diminished ovarian reserve, which means the number of eggs left in your ovaries is declining, provided the protocol you use is individualized. You cannot use a one-size-fits-all, because if you've got diminished ovarian reserve, especially when it's associated with endometriosis, your likelihood of getting good quality eggs is diminished. If you use a one-size-fits-all recipe approach, the eggs that you get will very often not be optimal in terms of their potential upon fertilization to make good quality embryos or blastocysts. So for that reason, I cannot overemphasize how important the protocol chosen should be. If you use the right protocol, given that age is in your favor, and you don't corrupt the eggs any further by creating the wrong ovarian environment for stimulation, you should be able to get eggs and have a baby. Remember what I told you earlier on if you were here. There's another condition that often goes along with endometriosis. In a third of cases, and here it's regardless of the severity of endometriosis, stage 1, 2, 3, or 4, there will be an underlying immunologic implantation dysfunction, which we were the first to describe for this condition some 25 years ago. This condition is associated with overproduction of what we call activated immune cells known as natural killer cells in the uterine lining, and they produce toxins called Th1 cytokines that attack the embryos and destroy their root system so they can't attach properly. You've got to identify, quantify, and typify that problem. And the problem is there are only 3 or 4 laboratories in the United States that can do the tests necessary with sufficient sensitivity and specificity to allow you to get the right results. You cannot send your blood to a local reference laboratory in your area. There are only 3 or 4 labs in the country that can do this. The one I use is called Reproductive. They're in Boston. We can arrange to get you tested, because if you put good embryos into the uterus, but you haven't corrected for the activated natural killer cells that are overproducing type 1 or Th1 cytokines, you will not get pregnant even with good embryos. And that is avoidable if you approach this in the right way. Remember what I said earlier. There's got to be a good seed. That means an embryo that's genetically competent to make a baby. And that means it's got to have all 46 chromosomes present, confirmed by PGTA testing, which in turn to get there requires that the right protocol be used to stimulate your ovaries. And then you need to place that seed, that competent euploid blastocyst, advanced embryo, into a receptive uterus that is either receptive because it's been shown not to have activated natural killer cells, or rendered receptive through selective immunotherapy with intralipid, steroid, and Lovenox. These are things we can discuss. I urge you to read up on it by going to my books that you can get free of charge by simply clicking on the link, Get those books, read them, and then you'll also get a free article that I've written with Dr. Tortoriello and Dr. Ravi Kumar on endometriosis. I'm proudly and maybe even glibly saying, I think this is one of the most comprehensive and most carefully laid out step-by-step approaches with explanations for treating infertility related to endometriosis anywhere. And it's only about 10 or 15 pages long. So get the article and read it. Once you've read it, you'll come to the opinion, and I think correctly so, that you need guidance. You can't just go rushing into doing the same thing over and over again. If you keep doing the same thing over and over again, you shouldn't expect a different outcome. And if you read the articles, and you get through that, then you may want to click on the second option, the checkbox for the second option, and that will get you the questionnaire that we've prepared. It's only 4 minutes long. It's quick to fill in. The moment you fill it in, it'll go to Patty, my office manager. She will reach out to you and set you up for an online consultation with me. You're under no pressure. But if you choose to have that consultation with me, and you do have US medical insurance that covers it, we will bill your insurance. Patty will be able to advise you on that. And if you're not from the United States and you don't have that kind of insurance, then the nominal fee of $250 for an hour of time and the report I'll send you is, I don't think, unreasonable, and you will get all the information you need. On top of it, everyone I consult with gets my contact information, a free cell phone number that you can reach me with anytime you like, even if you don't come to me. Once you're my patient and I've consulted with you, I'm available to you if you call me free of charge, and I'll be more than happy to address your questions.
All right, we're going to answer Angie here on TikTok. Says, does endometrioma always mean advanced endometriosis?
It is always advanced, not as advanced as it can get. Sometimes endometriosis can be outside the pelvis. There are cases where it's in the belly button, cases where it's in the kidney, cases where it's in the liver and lungs and brain. That's highly unlikely and very unusual. It's almost always confined to the pelvic cavity, but you can get it anywhere.
I'm going to answer AK here on TikTok. Says, can endometrial biopsy help find the cause of implantation dysfunction?
Again, one of the ways some people try to diagnose natural killer cell activation is to do an endometrial biopsy and look for specific types of cells in the uterine lining. Yes, you can do it. It's much more complex and it's not necessary. A simple blood test on you sent to Reproductive laboratory or one of the other 2 or 3 alternatives in the country, they will look for, number one, they will look for activation by doing a test called the K562 test, which cannot be done in a regular laboratory locally. Or they will do a cytokine analysis of your blood and let us know if you've got a predominance of the type 1 cytokine being produced. That will help us know if you've got activated natural killer cells. They'll also test you through doing antiphospholipid antibodies, which are often also elevated in women with endometriosis, and if they are elevated or activated, you then need to have adjunct Lovenox, which is a heparin-like substance administered. And they will also test you for what's called an immunophenotype, where they lay out all the lymphocytes so I can see very clearly what's going on immunologically. So you don't need to do a biopsy to diagnose natural killer cell activation, although it is a way to do it as well. Now again, you need to know more about this. I give you 2 books free of charge. One of the books is a thin book on the immunology of failed IVF. It talks about endometriosis and the natural killer cell activation. It's only 50 pages long. Comes to you free as a downloadable ebook, regardless of whether I see you and consult with you. There's no conditions. So go in there, click on the link, check the box which allows you to get the free books and the article on endometriosis. And then when you get the book and you read it, you'll see what I'm talking about. It's all in there as well.
All right, I'm going to answer Sophie here. Sorry if I butchered this word here. So I had a laparoscopy, and 2 months later got pregnant but miscarried. Could these be linked?
If you never had endometriosis, very often, in about 10% of cases, the laparoscopy flushes out the tubes and allows the egg to get down to where the sperm is waiting in the tube. Sometimes it's just plugged with mucus. So that's probably one of the reasons why 10 or 15% of women who don't have endometriosis and do laparoscopy get pregnant on their own. Now, it is possible also that when you did laparoscopy with the flushing of your tubes, you actually had endometriosis and were just lucky and got pregnant that next cycle. If that's the case and you have even the mildest endometriosis, please don't expect that your chance of getting pregnant next time around is any better. Because, as I told you, the surgery itself will do nothing to improve your fertility. And because endometriosis is a work in progress, it's always ongoing with new lesions being formed. Even if you remove some of them surgically, there are others coming up that are producing the toxins that damage the ability of the egg leaving the ovary en route to the tube to be fertilized from being fertilized successfully. So, no, the surgery itself wasn't therapeutic unless you didn't have endometriosis. If you got pregnant in spite of it if you had endometriosis. So that's all I can say to you.
We're going to answer Despina on TikTok here. It says, do I have to take birth control pills forever with endometriosis?
No, but because with birth control pills you suppress ovarian hormone production, it does have a quiescent effect. Also, it stops you from ovulating. And as I told you, pain in the middle of the month with ovulation is a common type of pain you get with endometriosis. So using the birth control pill will remove that pain that occurs with ovulation, and by making you have less hormone production will subdue the pain somewhat that you experience with menstruation. So yes, it is a therapy, but you don't have to take it forever. And of course, you can take it if you're trying to get pregnant.
I'm going to answer this one. The Glamour and Lux Avenue asked, even if I had done total hysterectomy, but doctor left one ovary, do the endometriosis still stay?
You sound like my own daughter. The answer is yes. If you have one ovary left over, that ovary can still cyclically produce estrogen. And if there are lesions that were developing already present in the pelvis, they can flare up from the ovary producing the hormone, and you'll get cyclical pain in the pelvis. It'll come monthly, like as if you were ovulating, and you'll also have pain with intercourse still. So yes, it can.
Well, you ready to answer a few more questions?
Absolutely, we've got lots of time.
Let's get it. Alright, we were about to answer this one before we went on to that. So it says, is there still a significant reduced chance of pregnancy with endo in the bladder?
Yes, because the same issue. If you've got endometriosis in or not in, but on the bladder, it will be present elsewhere in the pelvis, producing those toxins I told you about, and be equally likely to be associated with immunologic implantation dysfunction with activated natural killer cells. And if it's on the surface of the bladder, it's also more likely that it's causing scarring or adhesions around the tubes, which make them less likely to be able to pick up an egg off the ovary. So yes, no matter where the endometriosis is, it speaks to an underlying condition that I personally believe has a strong immunologic component to it.
Santa on TikTok says, what can one do to improve chances of getting pregnant after endometriosis surgery has been done?
We're back to the same things I told you. We have to plant a good seed. That means a blastocyst, which is an advanced embryo, which is chromosomally normal, into a uterus that is receptive. You can't put a good seed in a bad soil or a bad seed in a good soil. You have to put a good seed in a good soil. And it's the variables that affect the quality of the seed, the blastocyst, as well as the variables that affect the receptivity of the soil, the uterus that will determine success or failure. When it comes to the seed, I've mentioned this several times over again. One of the biggest mistakes people make, especially in older women with endometriosis, or women who've got diminished ovarian reserve, that means they're running out of eggs regardless of their age. The biggest mistake that is made is that a one-size-fits-all recipe approach is used for stimulation, which doesn't protect the eggs during the stimulation process. With endometriosis, especially if there's diminished reserve, it's incumbent upon the doctor to individualize the protocol. There's no such thing as a one-size-fits-all. There's no such thing as one height or weight for any individual, just like there's no such thing as one protocol for everybody. And too often, doctors use the same protocol on everybody, and that is not going to get you anywhere. Because if the seed's no good, it doesn't matter how good the soil is, you're not going to have a plant grow. The second thing is to be aware that the implantation in women with endometriosis is most commonly, but not always, there are other things as well, adversely affected by an immunologic component present in a third of women with endometriosis, regardless of its severity, how mild or severe it is. And you've got to identify, quantify, and typify it, and then regulate the immunologic environment. That's not something you just do out of a book. You've got to have a lot of experience to do that. And if you do the right thing and bring these cytokines into balance so that the embryo's roots can attach properly, you will solve the problem, and the chance of getting pregnant is just as good as if there was never a problem in the first place. I recently had a woman come to me who said that she'd repeatedly, on 7 occasions, had embryos that were chromosomally normal by PGTA placed in her uterus, and she'd not gotten pregnant with IVF. She had endometriosis. We tested her, we found her to have natural killer cell activation, treated it with intralipid, dexamethasone, which is a steroid, and Lovenox. And we put one embryo in her uterus. She ended up getting pregnant, but guess what? She got pregnant not only with one, that one split in half and made 2 babies. So she ended up with identical twins after having had numerous failures, only because we regulated the receptivity of the soil to the seed and then planted a good seed. I can't and don't know how to stress more importantly how important it is to focus in on the variables that can affect implantation and the variables that affect the quality of the seed if you want to correct endometriosis, and to avoid unnecessary surgery such as laparoscopy unless there's a major structural anatomical lesion that gets to be removed, which is not an endometrioma. Today we can remove these through sclerotherapy with the help of Dr. Ravi Kumar, who runs our program on sclerotherapy. I can help you get to where you need to be. All you've got to do is reach out to me. And so, again, it's terribly important to prepare properly, to make sure that you put a good seed in a good soil. And don't wait too long, because egg quality declines with age. When you get over 35, a very important point here, if you're over 35 years in age, egg quality is naturally declining. Up to 35, 2 in 3, or 3 out of 4 eggs a woman produces will be normal and able to produce healthy babies. After 35, simply through wear and tear on eggs that have been in your ovaries all your life, egg quality will decline. So after 35, you don't have time to waste sitting around trying to do this without testing the embryos and doing IVF to be able to get the best quality of eggs and embryos you can. The second thing is that as you get older, your egg population declines. You don't make any more. You're born with all the eggs you're ever going to have. And in your mid-30s and late 30s to 40s, the number of eggs remaining declines. And as the number declines, there are fewer eggs available to be fertilized. And because with age, egg quality declines, such that at the age of 35, 2 out of 3, 3 and 4 are normal. At the age of 45, only 1 in about 20 are normal. So you can see there's a slippery slope. The sooner you get the eggs out, don't wait after the age of 35 messing around with IUIs and surgeries in the hope it's going to solve your problem. It won't. You need IVF if you're over 35, or if you've got diminished ovarian reserve, meaning an AMH of under 1.5. And don't waste any time. You don't have the time to waste.
All right, cool. I'm going to answer another question here, but first I just want to thank our girl Peta. She is back. She's gifting us as well. Just like
lovely.
every week, we thank you so much. We look forward to seeing you here. Thank you for having you. We will answer your question in just a second. I want to answer this one here. Ms. Chi says, currently suffering from rectal endometriosis and endomyosis. 3 failed IVF, please help me.
The adenomyosis, unless it's associated with a thin uterine lining at the time of ovulation, under 8 millimeters, or there's an adenomyoma, a tumor caused by the glandular proliferation protruding into the cavity of the uterus, will not cause infertility. So it's only if the lining is thin. That's another story we have to deal with separately. It's a separate issue. There are ways to fix that. So adenomyosis and endometriosis are completely different conditions. But if you've got endometriosis anywhere in your body, even on the rectum, it's still more than likely linked to an underlying immunologic issue, and it is still more than likely associated with a toxic pelvic environment. And it can still be associated with damage to your tubes or the ends of your tubes. So, simply because it's in the rectum doesn't mean that it's not causing all of its devastation in the pelvis. But here's the good news. We can isolate those problems, address them, get you the baby you deserve and want. But to do that, there needs to be a strategic and systematic approach to treatment. One that I outline very carefully in the article that I give you free on endometriosis that you can get when you request downloading of the books. And if you want to talk to me, because it sounds like yours may be more advanced than you think with rectal endometriosis, maybe we should talk. Maybe it would be a good idea to set yourself up by asking for an online consultation with me. What you've got to do that, is click on the second box in the link, and that second box gets you the questionnaire you fill in 3 or 4 minutes. That goes to Patty. Patty will reach out to you, and then if you're so inclined, we will be happy to have a consultation with you.
Okay, we're going to answer our friend Peta. They asked, how bad is it to have light bleeding 6 weeks? How bad is it for light bleeding at 6 weeks, positive pregnancy after FET?
If there's light bleeding and no pain associated, no cramping, then I suggest you go and get another ultrasound done in a few days. 7 weeks is perfect. Check to see if the baby's heartbeat is there and is normal, up to about 180 beats per minute, 120 to 180 or 110 to 180. And make them check behind the baby to make sure there's no collection of blood, known as a retrochorionic bleed, and so they can watch that carefully. But most importantly, go and get another ultrasound. Sometimes the bleeding is not even coming from the pregnancy, it's coming from the opening to the uterus known as the cervix, which becomes very friable during pregnancy, so that after intercourse there's often spotting. Don't mistake that as meaning there's bleeding coming from inside the uterus. But the only way to separate the two is to get that further evaluation as I've described.
Alright, we're gonna answer Lowe's or Loss. It says, I have 1 endometrioma on my left ovary seen on a scan. Does this mean I have endometriosis?
Absolutely, definitively, yes. And if it's more than 2 centimeters, the eggs that you get from that ovary, in my experience, are more likely to be abnormal than from the other ovary, much more likely than your age alone would dictate. So it's really important, if it's more than 2 centimeters, to get rid of it. And again, you don't need to do surgery to remove it. Removing surgery removes some ovarian tissue, more painful, more expensive, and no more successful than the outpatient procedure which I described as sclerotherapy, which I personally believe is a game changer. Again, if you click on the first box in my on my bio, click on the link, go to the first box, and ask for the books that I've written for you to read. You'll get a lot of information there, but with it will come an article that I've written on endometriosis, which I think will be very helpful to you, and read up on the issue of endometrioma. If you then want more, I'm afraid we should talk. And there are not many people that can give you the input on this, and I think we can, either me or Dr. Ravi Kumar. So all you can do, if you want to, is then click on the second box, and that'll get you to Patty after filling in the questionnaire, and Patty in turn will set you up to speak with me online to have a consultation.
We're going to answer IVF journey here. They asked, will endometrial cancer stop me from getting pregnant even though it's gone clear since October?
Endometrial cancer,
Yes.
if it's definitely gone and tests have been done to show that it is absolutely gone, then you should be able to get pregnant, but it's not something you do lightly. You need to be evaluated by a gynecologic oncologist to be absolutely sure it's gone. Very often, it's not endometrial cancer that you have, but rather a condition called endometrial dysplasia, which is just before the malignant stage. And many doctors misdiagnose endometrial dysplasia with endometrial carcinoma. If you've got endometrial dysplasia, treatment of that in advance removes the problem. But if you had true endometrial cancer, and especially if there's still a remnant of it remaining, it's probably not a good idea to try to get pregnant.
It's a good one here. Motivation asks, cyst on ovaries, does that mean I have endometriosis? An
ovarian cyst is not commonly due to an endometrioma. It's filled with clear fluid, and having a cyst can be either functional or due to a tumor. A cyst occurs when something is stimulating the growth of that cyst, and so more and more fluid develops. And that occurs functionally if there's a hormonal imbalance. So your doctor needs to check that out. An endometrioma is different. You can usually differentiate between a regular cyst and an endometrioma quite easily by ultrasound. And if that's difficult, you can do an MRI of the pelvis. But if you've got a cyst that is clear, it's not an endometrioma. And then treatment depends upon whether it's functional or a tumor. If it's a tumor, it means it's capable of independent growth. It doesn't grow because of being stimulated by hormones produced by your pituitary gland, such as FSH. It grows on its own. That's a definition of a tumor. If you've got a tumor that's grown there, that probably should be removed to make sure it's benign, which it almost certainly will be, but remove it to make sure. If it is an endometrioma, you can remove it with sclerotherapy, as I've mentioned before, or you can remove it surgically. Now, if you're not looking to get pregnant, then remove it surgically. Who cares if some of the eggs are removed? But if you want to have a baby still, you probably want to think about preserving ovarian tissue by using sclerotherapy.
We're going to answer Charmed on TikTok. They asked, what size of an endometrioma should go under sclerotherapy?
You can get rid of any sized endometrioma with sclerotherapy, any size. But it doesn't need to be treated if it's under 2 centimeters. From a fertility point of view, you can simply go in before the cycle starts and drain the endometrioma and go on with the cycle. But if it's over 2 centimeters, it's going to cause problems in that ovary, and it should be removed, in my opinion.
Does endometrioma cause hormonal imbalance and mood swings? That's from Lowe's on TikTok.
Firstly, an endometrioma itself will not. But if you were erroneously placed on Lupron to get rid of or shrink the endometrioma, the Lupron can cause hormonal changes that cause you to have hot flashes, night sweats, and irregular bleeding or absence of periods. That can happen from the treatment of the problem. So the answer is the endometrioma will not in of itself cause an endocrinologic problem unless it's large and it has a lot of testosterone production causing the ovary to start producing hormones irregularly.
Okay, we're gonna answer this one. It's a really good comment. Also, I believe, um, thank you for the gifts as well. This is the same person, Shali Sharma on TikTok says, what can you eat slash which supplements to take before starting IVF to get best results with endometriosis?
Well, what you've got to eat has got nothing to do with the endometriosis. They're two separate issues. Eat healthily, live healthily, enjoy life healthily, activity, sexually, physically in any way. Try not to be overstressed. Avoid taking recreational drugs, alcohol, too much tobacco. Don't indulge in using marijuana too much, other drugs. Stay away from those things. Excess of anything is not good. But if you want to know what types of nutrients, of nutritional supplements are good for you to get pregnant, well, the most important one is folic acid. Then comes coenzyme Q10. Then comes omega-3s, which are fish oil. Then comes things like vitamin D3, vitamin B3, vitamin B6. And I think the other thing that you can use is prenatal vitamins. I've got an article in my book, one of those you get free, talking about nutrients and nutritional supplements in IVF. If you read that article and get the book, by clicking on the link in my bio, you will be able to read up on how much of each of these medications are probably helpful.
Okay, I want to answer Aid on TikTok here. They ask, any chance to produce good eggs after 45 with endometriosis? There's also a lot of questions asking here, when is the cap rate to use your own eggs with endometriosis after 35, 45?
Again, at 45, in my opinion, and I've got the oldest woman that I know of that ever got pregnant with her own eggs anywhere, had a baby with me some years ago when I told her she could never do it. She was in her late 40s and she begged me to keep doing IVF. I did 6 cycles with tongue-in-cheek over and over, not feeling good about myself, such that the last 3 cycles I did free of charge. I couldn't, with good justification, charge her for something I didn't think would work, and guess what? The good Lord knew better than me. He got her pregnant on the 6th attempt. She had a baby, and I'm the godfather of that child, proudly. But it was also a lesson in humility. I realized I'm not always right, as my wife always tells me. So the truth of the matter is, you can get pregnant after 45, but you shouldn't be trying IVF after 45 because the success rate is so low. You make so many fewer eggs, and only 1 in 25 or higher are going to be normal. And an abnormal egg isn't going to make a normal embryo that make a baby. So my advice is for women over the age of 43 to preferentially be looking at IVF if they want to, with an egg donor, rather than still using their own eggs. Although it's never my decision, it's your decision. My job isn't to tell people what to do, it's to give people information so they can make their own choices and then give them the best option given informed choices. But I've got to know that the choices I'm giving them are informed choices. So we need that discussion first. Ultimately, it's always the patient's decision, not mine. In terms of what is the cutoff for endometriosis, same applies. It's an age-related and ovarian reserve-related. So you've got to check and see what the AMH is, see how many eggs they've still got, see how old they are, if they are in their mid to late 40s with endometriosis and they've got depleted ovarian reserve. It's foolhardy to try with own eggs. But the same rules apply if we use the right approach, have a high index of suspicion, go in and deal with underlying endometriomas, make sure that we address the endometriosis without being interventional. In other words, avoid using too much agonists like Lupron or doing surgery unnecessarily and waste more time in the process. If the woman is willing to try, we can do IVF as long as we look at all of the variables that affect the quality of the eggs, the number of the eggs, and the quality of the uterine lining for implantation.
We're going to reply to Hazy B here on TikTok. They asked, should we remove endo before or after IVF? I've had 2 rounds of IVF and now, sorry, I got to open up the message again. Now considering keyhole. I don't know if that's the right.
That's laparoscopy. You don't need surgery if you don't have insurmountable pain or complications from the endometriosis, or you don't have complications that have occurred from the endometriosis. If you've got an endometrioma, that would have been an indication for surgery to remove it, but with the advent of sclerotherapy, which I believe is the next big game changer in this field, you don't need to go through the surgery. You can do a sclerotherapy procedure in a benign, non-traumatic, relatively inexpensive and safe way. So I don't believe that that applies to you.
Alright, we're going to answer Victoria on TikTok. They asked, is the pill really the only thing that helps, as it is always the only thing prescribed in Europe?
The reason they give you the pill is to suppress ovulation, reduce the amount of estrogen produced by the ovary, and thereby prevent the proliferation of the existing endometriotic deposits, and stop you ovulating so you don't have pain with ovulation. And because they stopped you ovulating, reduce the severity of painful periods. Other than that, the pill does nothing. So why they only use the pill, I have no idea. I hope I'm wrong and they don't only do that. But the pill is a supplemental treatment to reduce symptoms. It's not going to improve your fertility gradient one iota. Again, I invite you all to go to my bio, click on 2 links. One link, the first box, will give you an opportunity to receive, free of charge, 2 downloadable books that I've written. One is on the overall aspects of IVF. It's an operational manual, very up to date. And the other one's on the immunology of IVF and implantation. With those books, free of charge, comes an article I've just completed 2 days ago with Dr. Ravi Kumar in New York and Dr. Drew Tortoriello. Please read that article carefully. I know, I'm not questioning, I know that if you read it, it may change your insight into the whole area of endometriosis, how it should be diagnosed and treated. The second option are for those of you who feel, no matter where you are, that you're still spinning your wheels. That option is to have an online consultation with me. If you click on the second checkbox, up will come a questionnaire. All you do is fill it in. It takes 4 minutes to do it. Once you fill it in, it'll automatically go to Patty Converse, my office manager. She will reach out to you. And when she reaches out to you, she will discuss with you how you want to proceed. You have 2 options. If you have US insurance, medical insurance, you will be able to have that consultation with me, which is an hour long, covered by the medical insurance. If you don't, or you live from out of country, unfortunately there's a fee of $250, which is pretty reasonable. In fact, I've reduced it by almost half to make it more affordable. So you can talk with me with that consultation in place. Patty will help you take care of that. And then you and I will have an hour consultation. I will develop from that report a full-length report with a planned layout on what you should do. And after the consultation, I'll send that to you. I just want you to know that when I have a consultation with someone, I regard them as my patient. And so, regardless of whether they ultimately get treated by me, I am always available to them. I share with them my contact information, which includes my personal cell phone number, through which they can reach me free of charge, whether I treat them or not. They're not compelled to come to me. But once we've consulted, I'm available to answer questions. All you have to then do is call me, because you'll have my number, and I will always respond. Anybody who knows me will tell you that. There is no charge for any of these consultations or these discussions we have when you reach out to me through my cell phone. And when I'm done, I think you'll have a much better insight into your problem, and you'll feel more comfortable too. So take advantage of this offer. It's not going to be there forever, but it is there now. I really prefer to practice medicine in the knowledge that I'm always able to educate and inspire my patients, and that's what this is about.
Answer Umzi, if I pronounced that wrong, I apologize. But here on TikTok, they ask, what can it be when you have all the endo symptoms but don't see it on a scan?
You probably do have endometriosis. Go and do a BCL6 or a receptiva test with your regular gynecologist. You get the results in a few days. It'll tell you if it's positive that you have a 90 to 95% chance of having endometriosis. Then it doesn't matter if they're lesions, because the treatment is the same. The underpinning of a toxic environment can occur even before you can see the lesions surgically or at laparoscopy. And if you see them, it doesn't help getting rid of those you see, because for every one you see, there are another 20 or so coming up. So even if you remove everything a few years from then, you'll have them back again. And it means that the toxic environment is there, and there's a 1 in 3 chance you've got an implantation problem immunologically. And unless both of them are addressed, you're not going to solve your problem. Again, I can't overemphasize how important it is to have a full comprehensive understanding of your disposition, or you're going to keep spinning your wheels until eventually you've run out of time. And then nobody's going to be able to solve the problem for you unless you are willing to go to an egg donor.